Good afternoon, everybody. My name is Byung-Hoon Kim. I'm jointly affiliated at the Department of Biomedical Systems Informatics and the Department of Psychiatry in the Yonsei University College of Medicine. Today, I'm going to talk about generative AI in neuroimaging and psychiatry. And the subtitle is Advancing Research and Clinical Care. Today's topic is kind of focused more on technical aspects, but I believe that soon these technical aspects will be translated to clinical psychiatry too. So today I'm going to talk about first generative AI and then generative AI in psychiatry and neuroimaging. When I talk about generative AI, I usually start up my talk with this news. It's already more than a year ago. In late 2023, the OpenAI's chief scientist who helped create ChatGPT, the CEO, Sam Altman of OpenAI was he had to resign temporarily because the chief scientist thought that AI safety was not ensured with the GPT development process. I think this is a very important point in the field of generative AI, in that this scientist, Dr. Sutskever, has been consistently bold in his statements about AI. He declared that AI might already be slightly conscious, and he says that even superintelligence, which surpasses the combined intellect of humanity, could be developed within years or decades. So we should be very cautious about something that is more intelligent than human being can be around us, because we have never experienced such thing before. Now, the reason that the scientist was very worried about is based on the technical recent development of generative AI. And first, I think I need to mention this transformer. Which is the backbone of recent generative AI models. A transformer is, in short, based on a mechanism that is called self-attention. So if you input a certain sentence, then the tokens, which are the basic units of the sentence, are learned to the transformer models are trained to learn the interaction, the attention between the input tokens within themselves. So it's called the self-attention mechanism. And based on the self-attention mechanism, generative pre-training of these transformers have revolutionized the generative AI. What I mean by generative pre-training is that some kind of a training mechanism that does not require answers, but the data itself. It is possible, two of the most widely known generative pre-training methods that I would mention are the GPT and the BERT. GPT is kind of an autoregressive next token prediction generative pre-training. So if you have a transformer, they learn to predict what kind of next word can come after that. So if you first input I, then it's trained to predict what can come next. For example, I went. Then you input I went, then it comes then to a cafe, and autoregressively it is trained. This is very interesting because, as I mentioned before, it does not require kind of a labeled data, but what you need is a very large corpus of just natural language texts, which you can scrape from the internet or other sources. You can mask the last word and given the previous tokens, you can just let it predict what will come next. BERT is a very similar idea, but it does not predict the last token, but it masks someplace within the sentence and predicts it bidirectionally. So this is a very important graph. It's called the neural scaling law. So if you pre-train the generative transformers with more data sets, with larger parameters of the models, with longer compute, then the test loss, which means errors, it consistently decreases. So if you train with more data, text languages, and with bigger artificial intelligence transformers, and train it for longer time, it consistently become more intelligent. This is a graph from the GPT-3 paper, which was published in 2020. As I mentioned, if the parameters grow, then the accuracy becomes consistently better. But what is more interesting is this part. Well, the x-axis is the number of examples in context. What in context means is that you give the examples within the input, which is not the training process, but within your inference time. If you provide more and more examples in context, then certain accuracies get better. Well, it can be presumed by the neural scaling law that more examples in context, then better outcomes are expected. But if the parameters grow from 1.3 billion to 13 billion, and then to 175 billion, the graph, the accuracy, when given only one example, grows much steeper. And what is more interesting is that even if you don't give any kind of examples that you can consider during inference, you can still perform an untrained task just by pre-training the AI. So this kind of capability of generative AI that it can perform tasks which were not explicitly trained to is also known as the emergence property. So this gives rise to large language models. So if you train with a very large data set and parameters with very much compute, the performance of the language generation gets better and better, and it can eventually perform tasks that were not explicitly trained to. So there has been a surge of a lot of large language models which are kind of open sourced or proprietary. So I'm sure that most of the people here have already access to Claude or ChatGPT or that kind of large language models already and familiar with. These are also referred to as foundation models too. So the concept is that not only the text, but images, speech, or other structured data, if large-scale training with large-scale parameters are done, they can be adapted, whether fine-tuned with only a few examples or even not fine-tuned, but they will be able to perform tasks in various multitask scenarios, such as question answering or image captioning. And the concept is kind of now being proved from, as you can experience from the products that are available these days. Now, in the point of medicine, these foundation models can be constructed based on medical data too. So a perspective paper in 2023 in Nature called Foundation Models for Generalist Medical Artificial Intelligence, they expected that this kind of multimodal, generative, self-supervised training of medical text data, audio data, images, and all the medical data along with medical domain knowledge, it will eventually be trained to be able to have flexible interactions such as Q&A exchanges with the clinicians and with multimodal inputs and outputs with high medical accuracies, clinical accuracy. So it can be adapted to bedside decision supports or grounded radiology reports or augmented procedures such as doing the EGD. You can just ask what you see to the AI and it can explain that it kind of looks like an aorta, so you must be cautious or something like those. If the foundation models can have flexible interactions, it is now, we can just feel that they are not some kind of a model, but they are like people interacting with me. So recently, people are referring to these flexible interaction foundation models as AI agents too. So it shares the core idea, the generative pre-trained AI foundation models and the AI agents are basically they share the core same idea. But if you think of AI as an agent, you can place a lot of vertical AI agents, which are specialized and domain knowledge proficient agents so that they can collaborate together to get a better result. So this kind of AI agents are expected to and are actually advancing healthcare recently. This paper was published in Nature recently in April, and it's called Towards Conversational Diagnostic Artificial Intelligence. So it is a conversational AI, which I mentioned like an AI agent, and it performs diagnostic procedures. So it was evaluated by a patient actor with a scenario pack, which kind of requires a little bit of more accurate validation, I think, but still, it performed very well when compared to the primary care physicians. What we need to take away from here is that AI is becoming models to agents, even in the field of medicine. So they are like people, and now people are trying to get better and better, more accurate results from these AI agents by letting them think more and more and think deeper. So this is called the test time scaling, and it's a recent paper, preprint, called the test time scaling for medical reasoning with large language models. So if you provide them more thinking budget, which means that you need to think more and more before giving out the final answer, then the final answer gets better. So this is also kind of a very important point in AI agents too. So I'm going to move on to the generative AI in psychiatry. I have done this experiment 2 years ago, but it is still in press and will be released soon at the British Journal of Psychiatry. I wanted to evaluate whether the models, the GPT-4, proprietary models or open source models, are capable of doing very simple tasks of making primary diagnostic impression or asking them to solve knowledge tasks like multi-choice questions from the DSM-5 TR-based clinical cases and test questions. What you can see is that GPT performs better than kind of physicians who are in training. But what I really wanted to say is that it's not important that it's better than the early primary physicians in training, but if you give them that for the answers that the physicians did not match the GPT-4, they are given the answers from the GPT, whether it is right or wrong, it doesn't matter, but it is given to them and will you change your answer? And they changed their answers and the accuracy got up significantly. It means that it can be kind of a pitfall because clinicians are actually influenced by the suggestions of the AI, even though they are not clinically validated that they're giving the accurate answers. But still, it means that the AI is smart, even in the field of psychiatric knowledge. This is a study performed with Professor Chu and Professor Son. So we tried to make a summarization of the stressor extraction from the interview data of the PTSD patients. And we showed that it can very well summarize them to help the psychiatrist's evaluation process. So these kind of summarization or solving test questions can be a direct implication of the large language models, but what we are thinking is that they can be extended to AI agents for psychiatry. And the preliminary form should be probably conversational agents. So people are interested in creating LLM therapists, which can mimic actual therapists as with conversational agents. So this work in arXiv last year has investigated the behavior of the LLM therapists, which are just prompted or instructed to act as a therapist. And it showed that, well, the problem-solving aspects or a lot of aspects were still not very much desirable yet. But this work kind of preliminarily investigated the conversational agents' capability, so we don't know whether they can be very better soon or not. However, it's really difficult to quantitatively or objectively assess whether these new conversational agents for psychiatry or therapy is actually doing good or bad. Well, as a professional psychiatrist, you can make a conversation with the agent all the time for like 30 minutes and say that this agent is like 80 out of 100. But still, it's kind of not objective, and it takes a lot of time of the professionals. So what I was recently interested was to provide a framework for evaluating these conversational agents for psychiatry in a very clinically relevant, ethically safe, and cost-efficient, which is also quantitative way. So this psychiatric assessment conversational agents can be evaluated with real patients, and psychiatrists can deal with, assess the quality of the conversation, or a simulated patient from a LLM can make a simulated dialogue between them, and the psychiatrist can evaluate them, but they are still not very quantitative or clinically relevant. So what we proposed was to generate first the ground truth of the patient behavior and mental status examination and history, and it is provided as a guideline for the simulated patient of the LLM. So the simulated patient with a multifaceted construct does a conversational assessment with the conversational agent, and the result is summarized by the conversational agent, and it is compared with the ground truth psychiatric assessment list. So you can score them now, and we had a kind of a good results, given that a lot of for 7 diagnostic categories, including the PTSD, they had a very high average of conformity assessed by multiple professional psychiatrists from the history aspect and the mental status aspect. And it correlated well with the expert score in the conversational agent's quality in their interview. Another aspect that generative AI can help in psychiatry is kind of more biological, is more from a biological perspective. I'm interested in neuroimaging, and neuroimage data can help rule out psychiatric diagnoses, but still they are not directly very clinically helpful in making the final diagnosis. But if we train a lot of fMRI or EEG data with large models, then theoretically you can get some kind of a foundation model of the brain which has emergent property that can reveal something that we cannot expect or is not explicitly trained to. So what I am interested in is building the foundation models of the brain. So you have a brain neuroimage, and you can construct kind of a functional connectivity from the brain neuroimage. And if you train them with the deep neural networks, you can get a representation vector which can be used to classify diseases or regress them as symptom severities. But this classical approach can be turned into generative pre-training processes too. Some of my earlier works were interested in developing the deep neural network structures which can supervisedly learn to classify or regress the patient phenotypes from input neuroimage data and the functional connectivity. But what I am more recently interested in is to provide some kind of a generative pre-training scheme of these deep neural networks given the neuroimage data to provide some kind of a better classification result or regression or explanation results from the patient. So this work under review is saying that the generatively pre-trained model of the network structure of the brain can provide better results in classification compared to previous ones. And this work also integrates, this does not integrate the functional connectivity, but it it directly incorporates the bold time series from the fMRI signals with stochastic optimal control. So we have a better efficiently pre-training scheme with better downstream performance too. I'm not going to talk about the details of these papers, but what we were trying to say is that if you generatively pre-train the neuroimage data with a lot of data and with big parameters, which are based on transformers or other recent models, you might be able to get some kind of a emergent property, which it is not seen yet, but I expect in the future. So to summarize and conclude, I think these researches can be translated to clinical care very soon, especially for the AI agents in the perspective of screening very early people with trauma. And for neuroimage data, you need a little bit of more time probably, but still they are expected to get better results when generatively pre-trained. And if the model is pre-trained with multi-model data and can have a flexible interaction as an agent, then we expect that this can probably provide more accurate decision support for the clinicians while giving flexible interactions to them or directly to patients maybe, which requires more clinical validation strictly. So this is the end of my talk, and thank you for listening.